Okay, my microphone was turned off, so I greet you, Mr. Allen, Dr. Allen. I see that we are only you and me. We wait a few minutes for other participants, and in 1 minute we start with the webinar. If you want, at the end of the webinar, you can pose me some question, and I will respond you. Un minuto. Well, hello and welcome at our webinar, Dr. Mohamed and Dr. Alexandre.
Hi.
Well, I think we could start with the webinar. I will speak to you about OccluSense. I think it's a very useful device that I use in my daily practice because it helps me to measure and control and manage occlusal forces. I am a prosthodontist and a neonatologist, and my aim is usually to avoid overload. Overload is not only occlusal, it's also muscular, articular, and frequently is related to extraoral problems. So a balanced occlusion means an occlusion in which the forces are correctly distributed in the global arch and without a bad response from the muscle and respecting the position of the TMJ. Well, if the occlusion is important, I think it is important to check the forces and how they are distributed on the teeth. Well, this is the company of Bausch. In Italy and in Europe, we know Bausch very well, but also in the world, because from when we were students, we used the occlusal papers of Bausch of 200 microns of thickness. Well, we will see how to use the occlusal papers in combination with the occlusal digital analysis. Actually, the papers have a different thickness, and we will see what is the difference and how to use it. Is an official video, but I think it's interesting to see how the occlusal paper are produced. Well, a company that have usual attention to occlusion prepared for us a simple tool to check the forces, to quantify occlusal forces. This is the classroom in the company. And I want to remember you that occlusion is not only a static situation. Occlusion means also dynamic relationship into the arches because the contact of the teeth is important in the static, but also during the movement of anterior, posterior movement of the jaw, or also in the lateral sided movement, in which we have contact, lateral contact to the canine or a group contact. And as I told you, we use occlusal papers to check occlusion of different thickness. Actually, we could add a tool to check the quantity of the forces. Here you can see an example of different thickness of the occlusal papers, and also different colors. It's really important to remember that you need to use at least 2 colors to check occlusion with occlusal papers or occlusal foils. Red color to check the movement, and dark color, black or blue, to check and superimpose the static position of the contacts. This is my tool with different occlusal papers. I prefer to have in my disposition different thickness, 200 microns, 65 microns, 40 microns, until those fantastic papers in aluminum, colored aluminum, black and white and red at 12 microns. I don't usually frequently 8 or 4 microns paper because we know the teeth can move into the position. So I prefer to use something that respects the moving of the teeth. But it's important to use different colors. As you can see here, balancing a splint, the movement, the sign of the movement on red, and on blue, the static positions to check different situations, static and dynamics. In the video, you can see 4 colors with 4 colors check of occlusion for the left or right side movement, or for the protrusion and retrusion, and then for the static position, anterior and posterior. But I think really that 4 colors are too much. With 2 colors, I can check every situation, static and dynamic. Here, my preferred occlusal paper in aluminum. And you can see in the instruction manual of Bausch, official manual of Bausch, the difference that you have into the foil of 200 microns or 40 microns. You have the possibility with 200 microns to have a scale of the intensity of the contact, but you have to be a little expert to check occlusion and to manage the intensity looking only at the point of contacts. Yes, it's possible you will have some contact more dark or less, but it's not really a quantity of the contact. And what is the mistake with occlusal paper? The mistake is the same value of the thickness of the occlusal paper. I mean, if you use occlusal paper of 40 microns, your mistake is 40 microns. 12 microns, your mistake is until 12 microns. in the real situation, occlusion is not perfect, and the patient have to adapt to its occlusion just a little or too much. What means bad occlusion? Bad occlusion is an occlusion not integrated in the system, not bad occlusion because the teeth are not aligned. This is a bad occlusion for an aesthetic problem, but a bad occlusion is an occlusion not physiologic, in which, for example, the muscle don't work too much, not so much, or so I have a bad response for the muscle. You can measure it with electromyography, for example, or I risk to have overload on the teeth or on some tooth, and or bad occlusion because my TNJ is not in a correct position and under overload could create symptoms and pathology. Here you can see some precocity of contact on a wisdom teeth tooth upper right, or an envelope, anterior envelope on the anterior teeth. I mean anterior envelope, a situation in which the jaw cannot move freely, is locked in only one mandatory position. This is not good for muscle and not good also for the cervical spine, for example. Some pain is possible you will have. And occlusion could appear simulate a good balance, but it's possible a stable position is not perfect for the TNJ. And after a treatment, for example, with physio or osteopathic treatment, or with a splint, it's possible you find a position that is correct for TNJ, but not stable, no more stable. For example, this patient, after the treatment with the splint, have no more pain to the TNJ, no more pain to the muscle, not tensive muscle, but in the new position, stabilized with the splint, his occlusion, or her, because it's a woman, the habitual occlusion is different than the maximal intercuspation. The habitual occlusion is an occlusion in which the patient is in more comfort but not stable. Actually, she needs an orthodontic or prosthodontic treatment, also combined, both combined. Well, are we sure that we can check occlusion, for example, with occlusal scanning or with the stems and the model of the patient? Also, in this situation, we could have distortion, as you can see in the left part of the screen. That we have two different scannings in which we can find in blue some difference. Well, so I cannot be sure that those scanning are accurate, and I'm not sure that the analysis of occlusion is accurate. Or we can see on the right part of the screen a situation in which the cusps show us some superimposition. This also is not correct for a correct analysis of the occlusion, but this is the real situation. Why you can find examining your scanning some superimposition? Because the teeth into their sides can move, can go up and down just a little, so the scan of the arches show some little superimposition because the excess of load can move the teeth. Well, if you check the models, the stone models of the patient, you will have not any movement of the teeth, and usually this rigidity create an increasing of the vertical dimension, just a little increasing, but the position on the stone model is not the same position, and the contacts are not really the same contacts that you can find in a real patient who clench very strong the arches, the teeth. Here you can see the little difference you can find in examining the scanning and the virtual models of the patient, in which you can see some little superimposition. It's just a little part of a millimeter, okay? But this is the ability of the teeth to move. But this is real. This is correct. And the final position is the correct position. If my technician have to design, for example, prosthodontic restoration, I prefer if find the correct intercuspation of the patient with the maximal load. And be careful with occlusion, because the papers and literature show us that usually occlusion doesn't create important pathologies in muscle or in the TMJ, but sometimes it could create, for example, if there is an acute change in occlusion with important different or vertical dimension of the teeth, of some teeth, new crowns in hard materials, for example, that it is possible that the symptoms developing immediately following the procedure of prosthodontic or orthodontic treatment. So also people and professionists and professors that usually tell that there is no relationship into occlusion and TMJ problems or TMD problems, really, if you read the papers, they tell that some relationship could be, is possible with some exception, as an exception. Well, how to control occlusal forces? I need, obviously, a check of occlusion and digital check of occlusion using a tool that show me the forces in each point of contact of the teeth. This is a paper that shows, for example, that using checking occlusal indicators, you can see a different situation, a different position of contact if you do analysis, digital analysis or a classical and traditional analysis. And in the lower part of the screen, you can see the columns that show us not only where are the forces, but also where is the first contact, where is the precocity that create a move of the jaw, that deviate the jaw. We cannot see it with the occlusal papers. Only using a digital control of occlusion. The patient clench on the sensor. Please clench it. Okay. Open. And you can see also the timing of the contacts, the first, the second, and then all the other contacts. And checking at the report of the tool, you can see high columns that mean high pressure, low columns that mean low pressure, and red color that mean punctual contact. The forces are totally in a single point of contact, or using the color graduation, passing from the yellow to the green, that the report show you how big is the contact area. So punctual contact in red, danger. I don't like so much the contacts that are very acute and punctual, because in the nature, in our physiological situation, we never have punctual contacts. You have little areas, or if you are a green dig person, also big areas. Well, smaller area on yellow and big areas of contacts in green. Using the scale of values, this is recorded using a sensor in which we have little sensors that have a piezo signal that create the difference of pressure into sensors and create this report in columns and colors. This is the OccluSense handheld. How is the sensor? Well, you can use two different dimensions of the sensors, 51 or 71 or 76 millimeters of dimension. It can capture 256 level pressures, so it's accurate, and it's very thin, only 60 microns. Be careful. Other instruments, competitors of Bausch, use a sensor that is 100 microns, so is less accurate, or is possible, is accurate, but the thickness could create a mistake. And it's in a flexible material, and this material coat the red color on the teeth, so allow you to check immediately where is the contact. It's very simple to position the sensor into the tool. It's not possible to have a mistake because there is only one correct position. You close your and prepare your tool. Position in the mouth. Please position the little arrow in the center of the sensor, at the center of the upper middle line of the patient, because the system will send a signal to the local Wi-Fi to an iPad, in which the OccluSense software show you where are forces, how much are intense and distributed on the arch, on the teeth, and what is the percentage of the load in each different tooth, and if the forces, and where is the first precocity. You can check the static contacts, or also, if you want, dynamics contacts. So you can check, for example, how are developed the contacts during the lateral sided movement, pure kinning guidance or group guidance, for example, or during the guidance, I have some precocity in the opposite side. And this is the report you can see. Obviously, this is an advanced webinar, so I don't give you the single instruction that I give usually in the first level webinar. Do OccluSense replaces the occlusal papers? No, it integrates it. But what is the difference? When you use paper or foils to check occlusion, you cannot see the first contact, initial contacts, because after the first contact, after the precocity, the jaw slides into a maximal intercuspation. So, like the little rod of the car in the picture, you can see only the final position of intercuspation, the final contact, or the final situation of contacts. But you cannot see what are the first contact and what happens during the sliding of the jaw. So with the occlusal paper, you have a photographic image, a static image of the occlusion. Using a digital control of occlusion, using OccluSense, you have the possibility to see and record the initial contact, the movement of sliding of the jaw, and then the final maximal intercuspation, the final position. Step by step, you can see each contact and the evolution of the contacts during the little movement of the intercuspation. So you are recording a movie. this is very useful. For example, when you check occlusion in a hybrid and different occlusal situation, for example, natural teeth versus prosthodontic teeth on fixture. And in this situation, shown in the video, for example, yes, I can check occlusion with red occlusal paper to check the movements, and with the blue occlusal paper to check the static position. I can try to check if my fixture and the crown of the implant is overloaded, but I'm not sure about this. And what happens during the movement, for example, of chewing? Well, it's possible I can check the forces looking at the report of OccluSense. And in the report is evident, immediately evident that I have an excess of load exactly on my prosthodontic treatment. Okay, this is the Sea of Italy. Usually you could check occlusion with usual occlusal papers, but some patients create in us a real worry. I am very worried about the grinding patients. And when this patient damaged his tooth and asked me for a restoration, I prepared for him a build-up and a tabletop, but I want to avoid overload and I don't want to have a mistake and a failure. Well, we can use the usual rules to project design a restoration, and not indirect restoration on the tooth. And remember, usually you think you can check occlusal contacts with the scanning. For example, here I'm using a trios, but the reality is that those are not contacts. This is a distance. With the model and the scanning of the arches, you only can see the distance. You can enjoy the different calibration of the distances, but this is not the same of an occlusal paper. Those colors are distance, more distance with green and a little distance a little thickness in red, but the tooth are not in contact. The teeth are not in contact. Well, we apply the restoration, but I want this restoration is designed by my technician respecting the real movement of the patient. So Rossano Canova, one of my technicians, we work very well with Rossano, receive from me the recording of the real movement and prepare a restoration, design a restoration that is immediately functionalized, because I don't want to lose my time with the patient correctly or correcting occlusion. I prefer to receive something that is perfectly integrated in the real moving of the patient, movement of the patient. And then we position the restoration and only a few minutes to balance, but it's not enough for me. As you can see, I prefer to maintain my iPad and the tool chairside for a really and useful daily use. I check occlusion to control if I have an excess of load on my restoration. Okay, the percentage of load on the report show me that neither with the gentle pressure, neither with a strong pressure, I have an excess of load on my new restoration. And looking at the disclusions, anterior and lateral sided, I can see that on the right side, I have a pure canning guidance, so I don't worry about the lateral forces on my restorations. On the left side, the caning guidance is not pure because there is a premolar that works with the and guide with the caning, but it's okay. And in the anterior movement protrusion, I have only a little interference on the posterior part of the arch, but not important. This cannot damage my restoration. So actually, about those patients, I feel good without worries because I can control the load on the teeth. Sometimes some tooth request a little risk. Why not to try to save this tooth? With my partner in our clinic, Christian Coraini, we prefer to try to save the teeth, okay, not to extract and do fixtured implants. Well, if the forces are not exaggerated too much, it's possible to try, but I need to check forces to have a risk. I know to measure the risk. I need to measure the risk. And sometimes it's not possible to control forces because it's evident that the tooth has a crack. We extract it, we position an implant and a new crown. Well, the forces that damaged the tooth obviously actually are trying to damage the fixture. Sometimes some fixture crack also. So when I position a crown on a titanium implant, I usually check what are the forces on this crown. And sometimes the same forces that damaged the implant, you can see here in my arrow, also try to overload the fixture here and show me that is important. This patient, grinding patient, during the night use a splint to protect the patient, the muscle, the TNJ, but also my prosthodontic work, my prosthodontic therapy. Overload is real in grinding patients, but not only, also in athletes and sportsmen or sportswomen. They are very, very strong and they could overload the teeth and damage muscle, TNJ, and occlusion. And a splint could help you to manage overload. The overload has frequently an emotional origin, but we cannot work on emotions. Only my psychologists in our clinics manage emotions, but I can manage the consequences of emotions. I mean overload. So a good occlusion, perfectly balanced, and if necessary, protecting it with a splint. So you can see the overload, effects of overloads. Overloads can be instant, sudden, or slow and constant, and frequently exhaust the ability of the resources of compensation and adaptation of the patients. If overload exhausts the resources of adaptation, I will have symptoms in my patients. Some patients overload because is very stressed, some other because it's very, very strong, like those two athletes. We check occlusion during the sports activity, and we can see that athletes usually clench when they load for their sports practice. Because bruxism is usual, is not a pathology, is possible, is very, very close to be physiologic activity, the bruxism. So everyone, or is very, very frequent that people brux and grind, and if they are also stressed or in a situation that create emotional problems, they brux some more, and we have to check their occlusion. I have to thank my colleague and friend, Professor Farella from Australia. He's Italian, but he works in Australia. That with Professor Ambra Michelotti, published in the past those interesting studies where they applied on one single tooth a thickness of 1 millimeter, creating a precocity, the same in all the patients. And then they checked the activity of muscle. Well, usually the application of the interference caused a marked reduction in the frequency and the intensity of the contraction of the muscle, measured with electromyography, obviously. But this not happens in the patient with an history of TMJ dysfunction or symptoms. What means this research? That usually the patient with a precocity don't clench, but the patients that have a history of TMD, symptoms, emotional problems, sportsmen, well, they clench also on the precocity, so they become symptomatic. And this recent research of Professor Michelotti, Ambra, very worldwide known in the neonatologic sciences, demonstrates that usually if the patient has high levels of anxiety or pain catastrophizing, so emotional problems, well, he exhibits a diminished ability to perceive the minimal thickness between the teeth antagonistic. So the patient don't feel the precocity. If the patient don't feel the precocity, he will clench very much. So if you work and do your therapy on patient with anxiety, for example, be careful, use a digital control of occlusion to check the forces, because you will see the forces, but the patient don't feel the forces, don't feel the overload, and he will crack your work. Let's look together some clinical case, why not? For example, it's frequent to see on the 7 tooth of the arch, in this case both on the side both, an excess of load that create a crack, a little crack. And this happens also on the splint. The splint is damaged in the same position. It's very hard to manage the situation. Frequently the tooth is symptomatic and the crack increase until determining the root canal treatment and sometimes also the extraction of the teeth. Well, we can check this is an athlete of a social, is a social player of an important team. If you check occlusion, you can demonstrate to the patient that his overload is evident in the posterior part of the teeth, of the arches, and you can show to the patient how much it's difficult to manage his occlusion. I don't know why he load more on the posterior right part of the arch, but for me it's important to manage forces, to have a good distribution, avoiding single point of contact that could damage occlusion. If you want, you can check occlusion also with electromyography. Electromyography immediately show us where is the overload, but show where is the overload analyzing muscle and show us that the muscle has a more intense activity on the posterior right part of the mouth. But on the tooth with the OccluSense. If you want to manage a splint, for example, this is not recent, is a node splint for this patient that is also an athlete very strong. Also, this splint is damaged on the posterior right area, and the check of occlusal forces, ocular contacts with OccluSense show me an excess of load in the posterior right area of occlusion. You can see here the report is very clear, immediate, also to show to the patient. And on the left part of the screen, you see a spirometric analysis did by his osteopath. And this analysis show a descending interference, a descending syndrome. This is possible. It happens, not frequent, but possible. Well, the osteopathist sent me the patient with this indication. The splint is no more balanced. It's possible it was in the past, but actually the splint is not balanced in local situation, but also with the global posture of the patient. So please balance it. I prepared for you the patient with an osteopathic treatment, so the patient can position himself in a correct position. And there is, in fact, a relationship into, for example, cervical spine and activity of muscle. Look at this patient. She's not clenching on the left side of the mouth. She only moved the jaw, moved the head. And moving the head, solicitate and contract and recruit the muscle only of the left side of the face. This patient, the patient that I shown you before, the teeth and the splint damaged and abraxed, this patient has a problem. He tell me, sometime when I jump, I cannot find the position of my right foot. So the osteopathist tell that is only a problem of occlusion. Well, usually it's not only a problem of occlusion, but is also a problem of occlusion. And my aim is to resolve and balance the problem of occlusion. Well, the patient has to do an interdisciplinary therapy, obviously. And please, I ask, please kindly to turn off the microphone, and we can answer to the question at the end of the webinar. And this is the analysis electrographic of the occlusion of the patient. The patient also did some training with a soft system to train muscle activities, to find a more balanced activity. Then we applied some new resin by blast sanding the splint without to do a new splint. The patient closed the mouth in his natural automatic and position, self-repositioned. And then we green the splint, finishing it and balancing it for correct daily use. Initially with a raw cutter, and then a thin cutter and a rubber. I prefer to go faster. I prefer to balance the posterior part of the splint using the cutter in a horizontal position because I don't want any interference in the lateral side and movement or in protrusion. I try to create Kaining guidance. I don't think that Kaining guidance are magic, are absolutely mandatory, but it's very easy to manage, to create and manage Kaining guidance. And they are usually very comfortable for the patients. So why not? Why to use another scheme? This is good, it works, it's the same scheme of the same pattern and scheme of the Michigan splint, for example, that is the almost used in the world. So I use it not only on the splint, but also on the prosthodontic treatments. Kaining guidance, why not? And only, obviously, a point of contact for each tooth on the arch. I like very much this little cutter that is thin on the apex of the cutter, and on the side of the cutter is raw. And this is the check. Well balanced, but again, a little excess of load on the posterior right part of the splint. Well, I'm sorry, the situation is this. I cannot green the splint and eliminate totally this load because the patient will lose the position. I need to maintain the position. I need stability. If the patient will green the splint during the time, I will prepare for you a new rebasing, a new repairing of the splint. But I tell to the patient, be careful, because when you have not the splint, you overload also your teeth in this position, you can crack the second molar. We are speaking about excess of load, so I love to work with athletes because they are very, very strong and they show me a very, very big quantity of load, of overload. Some of you know that I am a sport dentist also, being president of the Italian Society of Sport Dentistry, and in the future I will be the president of the European Association for Sport Dentistry. And I invite you at our Congress in Düsseldorf in October. You can find information on the website of European Association for Sport Dentistry. It's easy to find. And next week I will be in Lithuania for a Congress of sport dentistry in Vilnius. Well, look how can an athlete damage a splint? Creating overload on the lateral guidance. It's possible to manage it, obviously. For example, a little trick for you. If your patient grinding create an excess of load on the guidance and damage the splint, and in a few months the splint is very, very grinded, and the patient is in a envelope on the traces and signs grinded on the splint. So the position is mandatory, obliged, and not comfortable. Well, you can protect the splint, creating new guidance in composite. You can create the site for the new guidance in composite, as you can see in the video. Then you blast it to have a raw surface. Apply some resin, bonding resin, and create the guidance in composite. The patient will not abrax and grind the guidance in a little time. You need more time to grind them. So your position will be more stable. Athletes are very, very strong, but also people with emotional problems brax so much, and they usually damage in a short time your splint. So frequently I prepare the guidance individualized for the patient. Obviously balance it very, very well, because the composite is not so adapting to the movement of the patient. Is the dentist that have to adapt the splint to the movement of the patient. This is the result with an important load on the kinins. This is okay. And check the guidance on the mouth. Lateral guidance with pure canine guidance. Another example. You can check the guidance and the clench in the position, in the posterior position. Look at this. Here you can see two different guidance. On the right-sided movement, there is a group function, not only the canine, but also the premolar, but also some load on the incisors. This means the patient has not a pure lateral movement, but a movement on the lateral side, but also to the anterior part of the arch. Be careful if you are projecting, designing some laminate veneers, for example. Be careful because this patient, in the right lateral sided movement, create a load on the anterior part of the teeth, of the mouth. If the patient do a left-sided movement, we have a guidance on canine and premolar, but also an interference and a precocity on the opposite side. So immediately I go to check where is this interference. I don't want it. A case report for a simple but complicated approach on a patient that has a loss of vertical dimension, insufficient vertical dimension. What you can see when check the occlusion in a similar patient? Only an anterior load on the posterior part of the mouth, of the teeth. We have not any load, and the contacts are very, very gentle or absent. This patient needs an increasing on the vertical dimension. It's easy to prepare a wax with two different waxes, hard wax for the base and the soft wax to record the point of contacts of the teeth, with hot water, obviously, to create the possibility to modeling the wax. The green wax is more softer, and I apply it on the hard wax. So the system is less fragile, but accurate. And as usual, I give some space for the tongue, because if the tongue is displaced, it's possible your registration of occlusion is mistaken.
Okay. Après?
And then we ask the patient to close as you want. Prefer you to use the habitual position of the patient, prefer you to move the jaw. I don't finding a position that you choose yourself. What is important is to approach the patient with a reversible way. I mean that the technician creating some waxing, we are working now in this situation, not in virtual, but in real and traditional approach. And prepare for me stems from the waxing to apply on the mouth. Check the comfort for the patient, check the distribution of contacts on the patient, check aesthetics, and this is a position that my colleague prosthodontist that sent me the patient to study the situation could work to prepare a new treatment plan with an increased position, and the patient feel comfort. But I am happy and without worries, because I can see that the load is correctly distributed without excess of load. Just a little problem here in the anterior part caused by those disaligned teeth. This is the castle of Milano, my town. And look, an important and complex prosthodontic case that we managed with my partner in clinic, Christian Coraini. This patient needs a full arch restoration, prosthodontic restoration. I cannot show, because not the time, totally the work and the treatment, only the start, the initial and final situation. And in this situation, it's really, really important to check occlusion. Also, if you check provisionals, also if you check the mock-up that you can see here in the center of the screen. This is a direct mock-up. Immediately check if we have excess of load. Frequently, we have immediately relationship into the comfort of the patient and the load you can measure with OccluSense. Load perfectly balanced with OccluSense is also very, very comfortable. In other webinar, I showed a situation in which the patient told me, I have a problem, I have an excess of load, a precocity here. I checked with the papers, I didn't see nothing. And I asked to the patient to check with occlusion. Yes, check with occlusion. Well, an important column of precocity on a teeth that seems absolutely balanced with the occlusal paper. This is the mock-up based on the walks-up created by the technician in the position that we chose for the patient. Well, this patient chose by herself the position, the comfortable position. Only we applied it in the mouth with a mock-up and then with obviously the prosthodontic treatment. Before then, laminate veneers, crown, and important work. Before and then, before and then. But what happens after 5 years from the baseline in the same mouth, 5 years after the treatment, the patient tell us, I'm sorry, I feel something not comfortable. I don't know why, but I don't feel a correct contact. Something is wrong in my mouth. Well, check it with OccluSense, because I know you've seen a little problem. So we compare OccluSense report and occlusal paper points. Look at here and here. I don't know why, but this patient have an important precocity on the first lower right premolar. Here, this is marked with a occlusal foil of 12 microns. This in red the movements and on black the static position. I don't know why this tooth is in precocity. It wasn't in the past, but actually it is, and the patient feel. Obviously, if you use a more thickness of paper, for example, 40 microns, you can see also contacts in the other part of the teeth on the mouth. But those contacts, those signs, are a false positive contact, a false positive sign, because really the patient didn't touch here, only on the fourth. And the check with the Shinstock paper, 8 microns, show us that the teeth don't really contact. Well, I want to grind it, obviously, but I want to grind it under control, digital control of occlusion. It's important to be prudent with occlusion. Don't forget occlusion, or occlusion will remember you. Check it. What happens? A first correction, immediate, create an immediate augmentation of the points of contacts. We go with other little correction, obviously with the adapted cutters. And after the correction, this is the final situation. More correctly distributed. Again, I have here a little precocity, but not so important if you refer to the percentage of load in the arch. Only the 8% of the global load. 8% is not so much, it's okay. and the chin stock actually is retained. Don't slice. But you can do this only if you have a digital control of occlusion. Finally, if you resist, also this is an important orthodontic treatment that we did together with my partner Cristian Coraini in our clinic. The patient has so much of problems, some symptoms, and problem of vertical dimension, aesthetic problems, endodontic problem. But you can see this patient before the treatment is not able to move the jaw. He's in difficulty. After the treatment, he learned how to use the jaw in the best way. First and then, but what happens after some year? 8 years after the treatment, we find some teeth damaged. Here, for example, in the vestibular anterior part of the lower incisors, but also in the interior part of incisors. Here, in the lingual part of incisors, some chipping of ceramic of the upper incisors. So obviously we can do a restoration, but never without a control of occlusion. This is the Brooks checker from the Sato school to check the grinding during the night and checking if the patient have an excess of load during the night. Yes, he did bruxism not during the night. And checking occlusion and guidance, obviously we check the loads. And we can see that in some part of the arch, there is an excess of load. I don't know why the patient, after some year, reposition spontaneously their jaw. It's possible is an extra stomatognatic interference that create a natural repositioning. Well, also in the usual patient with natural teeth, we don't find the same position after 10 years. My position is switching on the right part of the arch. We correct it to find a more balanced position and occlusion. Well, use occlusal paper to see exactly where is the contact. Then check with OccluSense what is the timing of contacts and the intensity, and then check again with occlusal paper if you are if you have perfectly balanced occlusion. Okay, and this is a documentation for you, very useful. Before and after, use OccluSense. Check if there is a problem. Where is occlusal papers? And then check the effect of your adjusting. This is documentation, useful for the patient. So much of colleagues in the world use OccluSense in the last IDS in Colonia. I met so much of people from India, from Japan, from Germany, England, French. People love to check occlusion, and I think that a dentist needs to quantify occlusal forces. It's important to quantify occlusal forces. And I thank you for your attention. I hope not to boring you and that my bad English has been enough understandable for you. Thank you. This is the kit to start with OccluSense: iPad and Wi-Fi, obviously, and the kit of OccluSense with the handle and the sensors. Thank you again for your attention. And I see a question on the chat. Vediamo se riesco a sì. Vabbè, thank you for the presentation. Thank you for your attention and resistance, Dr. Alas and Dr. Mohammed.
Thank you, Doctor. I want to ask you one question. Excuse me.
I'm here for you.
Okay, now I have OccluSense, but I confused because I don't have which reading I should take. I have 4 seconds from I put the sensor in the patient. Which one I should take to compare before and after? The green become red and the red become green in the 4 seconds. So which one I should use?
You are asking me something about the time of the test?
Yes.
4 seconds or more. Well, usually I use 4 seconds only for 1 or 2 biting, no more. But if I have to check bite, static occlusion, and also lateral sided movement, and also protrusion and retraction movement, I change the frequency of the exam in 15 hertz to have a not too heavy exam to load on the iPad, and I set the time on 15 seconds. I prefer 15 seconds because the patient needs some seconds to adapt to the position, and this allows you to have to relate the position before and after the check. It's possible also to compare. You know, there is a button for comparison for different reports of the exam. I don't know if I answered you.
So we don't have raw data from OccluSense? Raw data?
We don't have
raw data to make use and research.
Raw data. No, there are other instruments that allow it to you, but only you have the final report, columns, and the percentage. The raw data is not possible to have it, obviously. No. But you can use the graduation of the color. You have 256 levels, so with the color you can have so much of information. For me it's enough.
Okay.
Okay.
Last question: how many times I can use the sensor for the same patient?
Oh, 10, 12, 15 times, no more. 10 times, sure.
Okay. Thank you very much.
Thank you for your attention. See you. Available for contact me. See you.
Bye.